And the recording is on. So good afternoon, everybody, and happy September. If you're new joining us, please mute your computer. You're always welcome to unmute as we go through to ask questions. We just try to limit background noise. My name is Dr. Karin Duncan. I'm one of the naturopathic medical doctors here at Coeur d'Alene Healing Arts. And today we're having our open forum for September with the topic of memory difficulty, brain fog, cognitive testing. How do we unlock the cause for changes in your brain? I'm really excited to see people here live. Through the summertime, it was challenging. People didn't want to give up their boating adventures to show up to a Zoom call. So it always makes it a little bit more fun when it's interactive. I have topics and presentations, and if anybody's a patient of mine, they know I could talk your ear off for probably 3 weeks on this topic without taking a breath. But really, that's not what we're here for. It is an open forum. We host those so the community can sign on, they can ask their questions, they can gain more information and share more information with either themselves, their families, their community, however it works. I don't offer personalized medical advice here, but I do offer generalized supportive recommendations if it needs to happen. So like I mentioned, I do have an outline. I do have some topics that I definitely want to cover, but the very first thing I like to do is open it up. Does anybody have questions that they want to make sure we do address during this chat today? And you can feel free to unmute yourself and go talk, ask.
I guess I would just, a question I have is how does hormonal changes, particularly during midlife, affect cognitive abilities and memory and so forth?
Okay, so I'm writing these in the chat box so I don't forget them later, but thank you. We'll definitely be addressing that. Anybody else have certain curiosities, questions they want to make sure gets addressed today? Going once, going twice. All right, please don't be shy. Bring them up as they come. It's really funny, you know, if you're acquainted with me at all, you kind of know a little bit about my story, but it's a good time to start. Like, why am I choosing this? I'm the neurologic focused practitioner here at Coeur d'Alene Healing Arts. I got into neurology because my own father had a neurologic condition in which I was a caregiver for over 20 years for. So I'm personally really intimate with neurologic conditions. And then just please mute your computers. If you haven't already, double check that they're muted. We are getting some background noise in here. I knew I always wanted to work with the brain, been fascinated with the brain. It's another universe. And what I've noticed in my professional career is that there are certain aspects of brain and neurologic health that are just kind of taboo for the conventional world to step into. And it's because there's unknowns, and there's a lot that our egos don't like about unknowns, and a lot that we can do either proactively or preventively when we see cognition changes. I've become much more passionate about cognitive changes in the last year or two because I get these referrals from conventional neurologists saying there's nothing else we can do for said patient, go see your naturopath. And it's exciting to me because I feel like there's a lot that we can do. Baby.
Okay, you can
again, if you're new to the chat here, if you could just go ahead and mute your computer. We're getting quite a bit of background noise here. You can always unmute to ask questions as we move along. Please feel free to do that. You can use the chat box. But while we're kind of in this space, we just want to keep the background noise down to a minimum. So we'll kind of talk about some of the major forms of dementia or cognitive impairment, and then I'll give a little bit more background information. And then what I'll do is I'll walk you through kind of an evaluation process that I go through in my office to see, you know, what's happening and what can we explore or investigate a little bit deeper to see what could be happening, right? Unlock the cause, try to figure out what's happening here. And then I just dabble in a little bit of treatment protocols here on this lecture, but I won't go deep because it's so individualized. So when we're talking about dementia, you know, the definition of dementia is a disorder characterized by a decline in cognition involving one or more cognitive domains.
Their screen.
All right, and I'm going to go into that again. I'm just going to remind everybody to please mute yourself. And I'm just going to start muting people that aren't muted yet. And so if you're muted and you need to ask a question, you can go ahead and unmute yourself. So the cognitive domains, we're talking about learning and memory, language, executive function, complex attention, perceptual or motor, and social cognition. So if I saw all of your faces here, which if you want to turn your cameras on, that's great. Again, we are recording, this goes on the internet, so you may not want to, but if you want to, it helps me not just look at a bunch of names on the screen, which is fine. But energetically, right, raise your hand if you've experienced a decline in any one of those cognitive domains at any point in your life, right? Yeah, I mean, you're all here. But also, you know, I'll just say I'm a mom, postpartum, went through probably 6 of them. So do I have dementia? No. Do you have dementia? Chances are no. Will the diagnostic criteria be met for dementia? Yeah. And that's what I think gets overlooked a lot of time, especially in our aging population. Another criteria for diagnosis is decline from a previous level of function. And who's to say what that previous level of function is? Typically we have a spouse or a significant other or a child who's coming to us saying, hey, you know, dad, hey, mom, you got to go in. Hey, honey, you got to go in and see the doc because I don't think you're doing as well as you used to be able to do. And then the other criteria for diagnosis is it's severe enough to interfere with your daily function and independence. Again, these are really vague diagnostic criteria that I think we all kind of oscillate in between based on different times in our life. By the time somebody walks through my door, they have typically been to multiple practitioners. They've typically tried a lot of different pharmaceuticals or are currently on a lot of pharmaceuticals. And they are to the point where it is so severe that I go home and say, oh, I wish they would have come in 3 years earlier, right? I wish they would have come in 5 years earlier. I wish I could have met them in their 50s to do some of the prevention. So I'm going to say it at the beginning, and I hope I remember, pun intended, to say it at the end, that if you notice a change in your brain or your cognition, I want to start to lobotomize the fear around it and treat it just as if you would if you had chest pain, right? People come to my office really often. I have chest pain. I'm worried I'm having a heart attack, and rarely is it a heart attack, right? But we're so concerned that something could happen that we come in at the very onset of symptoms. With cognitive changes, people are often very scared, fearful, secretive about it. They try to hide it from their family. They hide it from their friends. They'll blame it on, you know, not enough sleep or stress and things like that, which could be true. And also it's worth coming in and being proactive about, because if there is something else happening under the surface, then it's really valuable to get an early start on that. Some of those most common dementia syndromes are, as we know, Alzheimer's disease, which takes up about 60 to 80%, dementia of Lewy body, which is a Parkinsonism, frontal lobe dementia, frontal temporal lobe dementia. And then we've got other ones like Parkinson's disease dementia, PSP, CBD, MSA, Huntington's. There's vascular dementia secondary to stroke. So there's a lot of different flavors of dementia. But really what we want to keep in mind is that they all have this little like Venn diagram where they can meet in different places with nutritional deficiencies, stress, trauma, thyroid dysfunction. There's a lot of different physiologic support mechanisms that we can put into place to help either slow or stop or even reverse the progression. Again, as I mentioned before, it's not typically self-reported. We usually will get patients in here concerned about cognitive function much later in the process than we would like. And it's usually from someone else saying, hey, I think it's time to go see a physician about this. The most common complaint we see is forgetfulness. Hey, I'm just forgetting to do this. I can't remember certain dates. I can't remember names, word recall. But other signs and symptoms to be on alert for yourself and for loved ones is retaining new information. Are you retaining memories? Do you remember what you did last week in church? Do you remember, you know, visiting your granddaughter? Handling complex tasks, balancing the checkbook still applies to most of our population over 65. Though when we're talking about a younger population who probably has never balanced a checkbook in their life, then you might want to be aware of like the inability to handle other sorts of complex tasks. Reasoning, how are you coping with unexpected events? If there's chaos, if something comes up that you weren't prepared for, are you having a disproportionate reaction to that kind of stress that you normally would have, that ability to cope and reason? Spatial ability and orientation, are you getting lost in familiar places? Are you driving to the grocery store and then taking wrong turns on a regular basis and forgetting how to get home? Language, word finding, we talked about, and then behavior. Behavior is often the one that will probably be one of the earliest onsets and the least recognized, because we can attribute behavior changes to so many different aspects of our health and isn't really brought to the surface right away. Does anybody have any questions so far? Comments, questions, concerns? Okay, so the condition that I really want to focus the most time on is, before we get a diagnosis of one of those types of dementia, is what comes first, and that's mild cognitive impairment, or MCI. And MCI is a condition in which individuals demonstrate cognitive impairment with minimal impairment of instrumental activities of daily life, still functioning, still independent, but just having that little bit of deterioration in their cognitive function. The 4 criteria is a change in cognition, a change in your ability to do functional activities, an exclusion of delirium, so you're not delirious, so you might have mild cognitive impairment, or an exclusion of other competing mental disorders. Nowhere in the criteria to be diagnosed with mild cognitive impairment, I want to like bold and underline this, nowhere in the criteria of diagnosing mild cognitive impairment does it say exclusion of other physiologic abnormalities. We say you can have other mental impairments, no other mental diagnoses, but it doesn't say we've excluded other physiologic causes. And so what I see so often in my practice is, I'm coming in, I'm scared I have memory loss, give me all the memory tests, let's do an MRI of my brain, let's see what's going on. And we start chatting, and really what it chalks up to be, is it thyroid dysfunction? Is it diabetes? Is it hormone imbalance, like I've been asked about? Is it stress, trauma, grief? Is it the pandemic? Is it a viral infection? So there's so many other things that could precede a diagnosis of MCI. And instead of exploring those, we're handing out this diagnosis more and more regularly without doing some further investigation. So that's really what I wanted to focus on a little bit, and why the title of it is as unlocking the cause for changes in the brain. So when we first start an evaluation and you come in and sit in my office, and again, if you're a patient of mine, you can cheat a little bit. But one of the very first questions that I'm going to ask you is, does anybody have any idea?
Uh,
And if you're a patient of mine and you're not answering, then you're going to get not a gold star. I'm just kidding.
What day is it?
What day it is a great question. It is something that I will commonly ask. One of the very first questions I ask everybody who comes in my office is, what are you taking? What meds are you on that could be causing these changes in your cognition? So overlooked, so overprescribed, and not just what meds are you taking, what combination of meds. And then, you know, to get really on my soapbox, what supplements are you taking, right? Supplements, I say this in every single Zoom call that I have, every open forum, every time I have a platform, supplements are not always safe and benign and indicated. They don't always pair well with each other, and they don't always work well with your physiology. So what are you putting into your body that can be affecting your cognitive state? So that's one of the first things that we do. Then one of the next things we're going to do is talk about your narrative. Do you have a trauma history? How is your stress level right now? Are you grieving? Do you have community support? What's the mental emotional component to that? And in the conventional algorithm, it says screen for depression. It's one of the top things in an evaluation for mild cognitive impairment. However, I'm getting oodles of patients getting referred to me with a diagnosis of memory loss, with no screening, with no treatment, just, hey, you can either take this SSRI, but no real screening, no looking into trauma, no counseling recommendations to support people where they are. So I think it's in the conventional algorithm, and it's worth noting here, we cannot minimize the effect on our mental emotional state to how our cognitive ability works. And why it might be the most poignant and most important part to screen for is because they're both in the brain, right? We're not talking about thyroid. We're not talking about hormone imbalance. We're not talking about cardiovascular disease. We're not talking about nutrient deficiencies systemically, which also impact our cognition. We're talking about two different parts of your brain that are quite literally competing for attention and space. And if you are in a fear state, if you are in an anxiety state, if you are in a state of distress and despair and hypervigilance, then the part of your brain that's overactive, the amygdala part of your brain, that hypervigilant part, is going to shut down executive functioning and reasoning. And it sure as heck is going to shut down your memory recall, because the amygdala also stores memories. It stores the memories that, hey, we need to be aware of everything in our surrounding because we're not safe, we're in danger, we're in this fear response, we're in the sympathetic nervous system tone. So when these both are happening at the same time and we're not addressing the mental emotional component of memory impairment, it seems like a huge disservice to our patient population to just say, hey, I think you have memory loss, go see somebody else. There's nothing we can do, right? When there's so much that we can do to help restore and reverse cognitive function in that situation. Suffice it to say, I would be out of a job if all of us were balanced in our sympathetic and parasympathetic nervous system, right? Again, if you're a patient of mine, we've talked about it. We've talked about it ad nauseum, how important it is to regulate that nervous system balance. And if people were regulated, I wouldn't have a job. So my job security is your inability to get into the parasympathetic nervous system. But in all actuality, that's what society has dictated. That's why our health is poor, our chronic illness. And then we're seeing these cognitive changes happening earlier and earlier in life. My patient population who's coming in to see me with brain fog and memory issues is as low as 28 years old. And they're saying, I don't remember. I'm really concerned I have some sort of dementia. And it's scary to see that this young of a population is in such a nervous system state for so long of their lives that they've already gotten to this point where their memory is actually being impaired. Along those lines, for mental and emotional wellness is screening for ACEs. ACEs stands for Adverse Childhood Events. And why that is so important is there is research studies upon research studies that show that childhood trauma is a predisposing factor that correlates to long-term memory loss. And so if you have trauma as a child and you've experienced trauma as a child, you're more likely to experience memory impairment as an aging adult. And again, that kind of goes back into that amygdala overdrive and the nervous system imbalance. And there's so many more physiologic rationale behind that. But again, not being screened for your ACEs score in childhood trauma is a disservice to our patient population with memory impairment. So that's kind of the mental emotional component of that. Does anybody have any questions so far, comments? No, okay. So the next thing we do outside of the interview is, as we sit here and we're relaxed and we're having a conversation, it's establishing that rapport with you. And then there's a couple different standardized tests that we use for cognition. One of them is the mini mental status exam, and one of them is the MoCA test, or the Montreal Cognitive Assessment. These exams are not diagnostic in nature, but they do provide a baseline for how our patients are performing in that moment, so we can see if there's improvement, progression or regression of the condition, and kind of what part of their brain might be a little bit more deficient than others. There's visual spatial, there's memory, there's language. Different areas of the brain are tested in these exams. The mini mental status exam, you can Google it and see what these things are. I tend to do those in the interview. And so, as somebody mentioned earlier, hey, what day is it? And trying to get those into the interview where it's not a stressful situation, saying I'm quizzing you, I'm testing you, and taking away the stress and anxiety of being quizzed and stressed, is asking questions like, oh my gosh, I really, really love your shoes. Where did you get those? Right? Who gave those to you? Where do you get your hair done? What do you eat for breakfast? And then kind of getting into some more serious questions of like, can you understand abstract thought? A rolling stone gathers no moss. What does that mean to you? Right? And really starting to understand, are there parts of the brain that are not functioning as well? I recently had a patient who was referred to me for memory loss by his family. Went and saw his primary neurologist, said you're fine. Went and saw his PCP, said you're fine. We were sitting in the interview for about an hour, and we got through most of the interview and chatted and got everything right. And I asked when JFK was assassinated, and he said, well, it had to have been at least 10 years ago. And so the point of that is there's so many more layers to the onion to really unfold when it's cognitive decline, and people can hide it really well, sometimes without even knowing. And knowing what questions to ask and what situation to ask them is really important. So that's kind of what you can expect if you're getting screened for cognitive changes. But it caught me off guard because everything else was so normal. I was about to say, hey, you're fine. I agree with everybody else, so it's really interesting there. In the exam room, physical exam, I like to check for neurologic focal deficits. I'm going to check your reflexes. I'm going to check your strength, your weakness, try to rule out whether there's a cerebrovascular event or a stroke, if there's some sort of Parkinsonism or tremor, a gait imbalance, pupillary response. There's so many different neurologic tests. Again, if your doctor is not putting hands on you when you have a concern about your mental health or your cognitive state, it is a disservice to you. There is so much knowledge that we can gain from the human body and by doing a physical exam, that if you are not getting one, ask for one. I can't say enough, advocate for yourself. Hey, don't you need to do a physical exam? You want to check me out? So these things are really, really important for us. When it comes to labs and blood work, again, typically I'll see a very baseline blood panel associated with a referral or somebody who's coming in from somewhere else for a neurologic deficit. And I don't see B12 folate. I don't see a thyroid, a full thyroid panel. I'm not seeing any autoimmune panels. I like to run an iron and a ferritin, a homocysteine. Homocysteine has historically been reserved for cardiovascular disease, but really homocysteine is a byproduct of B12 metabolism. And B12 deficiency can lead to memory changes. And you can be taking B12 and having B12 in your bloodstream, but you could actually not be methylating and using B12 effectively in the biochemistry of your body, which would cause an elevated homocysteine level. And that can be neurotoxic. So there's a lot, again, even in the lab values that we look at to say, could this be causative or correlative to the concerns that you're expressing here? Lipid panel. Your liver and kidney enzymes. There's, like I said, so doing full blood work is actually really important when we're talking about cognitive changes too. And it's for two reasons. We want to rule something in. Hey, can this be contributing and can we fix it? Yay. Or two, is all of this negative and we've ruled out other concerns for your cognitive changes. So now we need to move on to something else therapeutically, and the sooner the better. Imaging is controversial. There's a lot of bodies out there that say we do not recommend imaging unless it was kind of an acute onset of cognitive changes. The AANP, or the American Academy of the AAN, the American Academy of Neurology, actually does recommend a brain MRI for all people who've been diagnosed with dementia. I probably split about 50-50 in my practice, just to be honest, who I send for an MRI and who I don't. And that's dependent on if I think at the initial intake that this is your organic run-of-the-mill dementia or cognitive decline without other physiologic causes, maybe they're contributing, but they're not causation, then I will send for an MRI. And at the very least, we're getting a baseline picture of your brain. Genetic testing, by the way, looking for the ApoE4 genetic allele is not recommended. I don't regularly run that in my practice. It can correlate with an increased risk of developing Alzheimer's disease, especially if it runs in the family. It is for informational purposes only, and again, is not diagnostic. In my experience, what it does is it incites a lot of fear and concern, and then we're exciting the amygdala part of our brain, we're shutting down our other lobes, and then we're having memory changes, which just proves that we probably should have not known that information to begin with. Any questions about diagnostics or tests that we would run for somebody coming in with changes in their cognition? Okay. So I want to get to the question that was asked at the beginning. It says, how do hormonal changes during midlife affect cognitive abilities? The research is vast. There is so much upstream and downstream shifts and changes to cognition based on hormonal changes. The overall stress on the body when we're experiencing menopause or when we're lowering our testosterone levels in our male population is stressful on the body in and of itself. It's adapting, it's changing. There's a lot of physiologic need and energy going into those shifts and processes, that there is going to be some cognitive changes kind of at a baseline level that should repair and restore. Now, the research on DHEA and estrogen being neuroprotective is miles long. So what we really want to do, and that's one of those baseline labs that I'll run, is a DHEA to say, hey, how is your androgen production in that biochemical chain? Because we do know that it's neuroprotective, and those lower values or imbalanced values can contribute to cognitive impairment. or brain fog or memory loss and things like that. So those hormonal changes will definitely affect, usually correcting those hormonal changes or addressing gut inflammation, which might be another root cause of hormonal changes if you're not in the middle of a transition, can help slow or reverse changes almost immediately. We see that all the time. You know, the other hormone that we talk about all the time that's easily corrected is thyroid. And one of the main side effects from thyroid imbalance is going to be cognitive changes or brain fog as well. Does that answer the question for you about hormonal changes, or are you looking for more specifics?
Yes, that answers it. Thank you.
Yeah. And I think it just goes to say that if you are perimenopausal, if you're feeling you have an androgen deficiency as a male, if you're going through, you know, these things, again, I want to bring cognitive changes so much more to the forefront, like we would chest pain or shortness of breath, that you can trust and understand that it could be transient and it still deserves care, right? Because if we don't use it, we lose it. We know this all the time about neuroplasticity. We know this about our brain, that if we have hormonal changes that cause just a little dip in cognitive impairment and we don't get treated or changed or addressed for that, and then we have, you know, maybe thyroid dysfunction, and then we have a major grief in the family, which causes stress, and, you know, then life, right, piles up and we continue to be in that sympathetic nervous tone, and our cognitive changes continue to increase in severity, and then our anxiety and fear around those changes are also increasing proportionately. Oftentimes, by the time you get to seek help, we're peeling back so many layers of the onion that it takes a long time to heal, even to get back to baseline. But I like to let everybody know, hey, if you even feel the breath of brain fog, if you even feel like, hey, I think this is affecting my cognition, I'm going through a really stressful time, get support. Protect your brain as if you would protect your heart. And so often what I see is it's people's biggest fear is to lose their cognition and to lose their mental capacities. Yet it's the last thing they'll go be proactive about. They're so scared to hear what might happen that they're actually neglecting that brain health aspect of it. And to me, that feels really sad and scary. Other things that I mentioned that can be contributory to cognitive impairment. And this is the time that I say, grab a piece of paper and write it down, because there are so many. Sleep, 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 sleep. Anybody have sleep disturbance? Gonna raise your hand and give a yoo-hoo. Sleep, sleep, right? So how many of you had a sleep study? How many of you seen a sleep specialist? How many of you been referred for sleep support by your primary care doctor when you go in for cognitive impairment? How many of you are even asked about your sleep when you go in to see your primary care doctor? Sleep is when we flush the toilet of our brain. This is not new information. They even gave it a really fancy name. It's called the glymphatic system. We have the lymphatic system in our body. It flushes out all the toxins. It gets rid of infection and all the debris. We have a glymphatic system in our brain, little tiny lymph channels throughout the entire part of our brain that reduces toxins and gets rid of debris. And it happens when we sleep. And so if you're not sleeping and you have buildup of this inflammation and oxidative stress and debris, chances are you're not going to remember well. You're not going to function properly. And if it's not being addressed and you're given a medication or you're given something else, even if you are asked about sleep and you come to me on a sleep aid, again, patience of mind, say, amen, sister, you're gonna rip that thing? No, I'm going to gently recommend, this isn't sleep. This is medicated sleep. This isn't sleep that your brain needs. This isn't restorative. This isn't anti-inflammatory. This is, hey, go to sleep. We want to teach your brain how to sleep. We want to involve your brain in the sleep process. We want to reinforce those pathways that it needs so it can do the work that it needs to do to clean out the debris. So sleep is really, really important, obviously. And we'll come back to that over and over and over again. And I'll even go so far to tell my patients, if we don't get your sleep in line, very little else that we do is going to be helpful in a sustainable way. Cardiovascular disease, perfusion, we're talking about perfusion. Are we actually delivering nutrients to the brain? Oftentimes I'll refer to the brain as an extremity, right? The things that get affected the quickest when we have a peripheral neuropathy or diabetes or an injury or, chemotherapy is our extremities, our fingers and our toes. Well, our extremities are fingers, toes, nose, penis, or clitoris. So those are the hardest places to perfuse. Now you have the brain. We have to go against gravity. We've got to pump it up. And then we've got the blood-brain barrier, which is the best set of bouncers you can ever imagine that, who dare pass through here. So now we're trying to deliver nutrients and support and blood and oxygen to the brain. And if we have elevated lipids, if we have elevated inflammatory markers, if we don't have the nutrients in our blood, if we have a nutrient deficiency, then it's not getting to your brain. And so we have to address perfusion when we're talking about brain health. Is it even getting delivered to it what it needs to function properly? Autoimmune kind of contributes to that inflammatory marker. Autoimmune disease will also inhibit the ability of the body to perfuse, to get nutrients. It can affect multiple different systems, but brain fog is often one of the very first things that I hear about with people with autoimmune diseases, and one of the very last things I see on their blood work until we start running some more extensive lab panels. Thyroid, I've mentioned thyroid before. Both hyper and hypothyroid, by the way, can contribute to brain fog. Hyperthyroidism is much less frequently diagnosed because it doesn't show up in the labs as easily, especially in a conventional setting. But it happens just as much, and it actually can mask as hypothyroid sometimes when you're getting your labs drawn. So we really need to be careful of, if you have a dysfunctioning thyroid, how are we regulating that and how are we supporting that process to help reduce the symptoms of that thyroid dysfunction, including brain fog. Infection, viral infection. Prior to the pandemic, we were talking about EBV and mononucleosis, HSV, neurosyphilis, right? We can't discount the neurosyphilis as being a part of cognitive impairment. It's kind of the stage 3 of a syphilitic infection. So oftentimes when people come in, I will ask, have you ever had an STD? And if syphilis is one of them, then we're definitely going to test for syphilis in the body. With the pandemic, I have so many long COVID patients with brain fog as being their number one chief complaint. So we know that the immune system and infectious processes are playing a part in a decline in the ability to focus, concentrate, remember. Toxic exposures, heavy metals, chemical exposures, different things like that. So those are things worth looking into. We can do a toxic metal test on your hair or your urine. Detoxification insufficiency. So whether you had a toxic exposure or not, are you able to detox? Is your liver working? Is your kidney working? Is your colon working? Do you poop? Again, patients of mine, amen. How many times talk about poop? Are you pooping? Are you getting rid? I mean, poop is toxic sludge. That's what it is. And if we're not getting it out, it's getting resorbed into the bloodstream and it's got to go somewhere. Kidney dysfunction as we age. I can't tell you again how many times I have people coming to me with their GFRs in the 40s and 50s and with cognitive impairment, and their primary doc saying, it's not that bad, you're in stable chronic kidney disease. And then you look at their blood urea nitrogen, the BUN on your lab test. If that's elevated and showing kidney decline, that's urea that's going through your bloodstream, and we know that can cause encephalopathy, that can cause brain changes. So the body works together. It's synergistic. These things cannot be isolated and say, oh, go see your urologist for this and that's not contributing because that's your kidneys. These things all work together, and if the system as a whole is impaired, then brain fog and cognitive changes is just a very expected side effect of that. Stress, stress goes, I'd like to say without saying, but again, so many times I'll have a patient and be like, well, this started about 1.5 years ago and and it's gotten a little bit worse, and kind of go through a story. What happened about 1.5 years ago? Well, I lost my husband to cancer. Okay, well, let's talk about that. How did you grieve? Well, I didn't, because I had 2 children to raise and this was happening and I kept going and I had to work and I had financial responsibilities. And okay, so did you ever cope with your grief? Have you ever come to terms with it? Have you worked through these stress levels? Have you balanced your nervous system out of the sympathetic? These are inflammatory in nature. These cause your body to not work in the correct lobe of the brain, and it's going to affect your cognition. We've talked about mental health ad nauseum. Hormone imbalance we addressed. Vagal nerve dysfunction kind of goes with that nervous system regulation. Your vagus nerve is responsible for putting you in the parasympathetic nervous system, rest, digest, restore, and heal. And we have so much data that shows vagal nerve dysfunction is implicated in our chronic neurologic diseases. I work really closely with our population with Parkinson's disease. And if the vagal nerve conversation doesn't come up in every single visit, then I feel like I'm basically medical malpractice. How are we stimulating that vagal nerve? How are we getting it to work? And how are we using that to properly get to this state of health and balance? Nutrient deficiencies, the list goes on and on. Again, I kind of said at the beginning, I could talk for weeks about this, about all the investigative work we could do for cognitive impairment. And that's what I feel like our patients are owed. There's so much, again, fear around my brain is changing. I'm having troubles remembering, and I was told there's nothing we can do about it, when we have so much data that says actually there is, and we want to improve the quality of life. I read Del Bredesen's work. I work a lot with his protocols. I think they're really, really phenomenal. They're not always attainable for the general population. And I think the more that we can incorporate into our treatment plan and pattern, the less we're going to see of these neurologic changes. Any questions until this point? So something that I wanted to share with you that I have been doing here personally at the clinic is I have partnered with a platform called Cambridge Brain Sciences, and I'm going to share my screen here in a minute so I can show you a little bit about what it's doing. Cambridge Brain Sciences is a phenomenal tool. It's it's science-based. It's been around for years. As far as the research, there's tens of thousands of volunteers that show that it's efficient and sensitive measures of baseline cognitive capacity. It outperforms the MOCA, or the Montreal Cognitive Assessment Tool, to get a baseline cognitive assessment and then to repeat measures. They have much more data there that will show trends and whether or not those trends are statistically significant, which is also really important. Somebody could score really well one time and then 6 months later maybe not score quite as well, but is that change actually statistically significant to show changes in the brain? Or is it just kind of a one-off? So it gives us that objective data and information that we need to say, okay, you're telling me you're having cognitive changes. I want to get a baseline measurement of what that looks like for you right now. Then I want to do my investigative work to figure out what else in the body and the physiology and the mental health sphere that we can work on and help improve, and do some of the neurologic supports. And then we're going to retest in 6 months and see how we're doing. And then we're going to retest in 6 months and see how we're doing again. And maybe it's every quarter. It just depends on what our expected changes are going to be. But it's really phenomenal because the test will assess cognitive, reasoning, memory, attention, and verbal ability. And what's cool about that is those are 4 of the major cognitive domains that we need to diagnose dementia, right? We talked about that already, is failure or decline in one of these domains. So if we're testing each of those individually, now we can focus and stratify our treatment to be specific to what domains of that cognitive decline that we're seeing. So give me one moment here and I'm going to share my browser. And so what I really like about the cognitive test through CBS is going to be can you see this right here where it says memory? Anybody answer me on that one?
Not with any detail, really.
No, okay. Let me change to, thank you. Stop share. I need to share my screen so you can see both of these things. Let's do this one first. Okay. So now you should be able to see this where it says domain, memory, test name, outcome measure.
Mm-hmm.
Okay. So what's really great about this is that there's 12 different tests and assessments with the Cambridge Brain Science test, and it's going through memory, reasoning, verbal ability, and concentration. And how is this applied clinically, right? Scientifically, this is great. Here's the name of the test, here's the outcome measure, and here's the associated brain regions. A lot of sciencey doctory talk here. Why this is really effective is I just had a patient who was concerned about early onset Alzheimer's disease. We got a treatment protocol started. We did a baseline cognitive assessment. And then when we repeated it after treatment, after 6 months, her memory was perfect. The memory part of the cognitive change hadn't changed. In fact, a couple of them had actually improved. The ones that actually didn't improve were the concentration part. Are you concentrating? Are you aware? Are you paying attention? Are you anxious? How was your attention span? And so by recognizing that it maybe wasn't this organic run-of-the-mill dementia or memory loss, it actually was an inability to hold attention or be present, which stemmed from, again, sympathetic tone dominance from a history of sexual assault, that we were able to say, hey, this is where we need to focus our treatment. It doesn't need to be on this organic memory loss. So what that gives us is able to stratify a little bit about what we're seeing. Now, when I go to this page, this one, you can see that. Now what this will show is task selection guide. This helps me as a provider pick out which tasks should be provided for certain patients. But what I really like about this the most is when we see an outcome measure that's not exactly what we want. Hey, we did these memory tests, the monkey ladder. Okay, they scored less than we would have liked them to for population management. Here's some examples. Can you plan your day and the errands you need to run, then actually do those? And then we use those treatments or those exercises in part of our treatment plan and the protocol to say, here's the parts of your brain that you were a little deficient in that scoring as well. Let's really focus on that aspect of your health for the next 3 months. And then we're going to retest and see if we can improve that. We're going to treat specifically for that. Maybe it's magnesium, maybe it's meditation, maybe it's a cleaner diet and figuring out what inflammatory causes are, making you have these changes. But really what it's doing is it's stratifying this very unknown and vague concern of, hey, I'm having cognitive changes, and it's narrowing it down into saying why and where do we focus? Because so much of the fear, I think, in coming in the first place is thinking, I'm going to lose my independence in my home and I'm not going to be able to drive. I mean, I've heard it all. People just right down the rabbit hole of what's going to happen, when really I'm like, hey, hold on. I ran your labs and your thyroid is all defunct. Let's start there. Like, we don't have to be in panic mode. So it offers a lot of insight. And when I say here's the key to unlocking the cause, it's a combination. There's so many keys, but it really is a combination of investigative work. But for me, the most important part of the evaluation is this objective data gathering of, can you do this 12-step assessment? Not only included in that objective data of the 12-step testing is then subjective questionnaires. What is your anxiety score? What is your depression score? What is your PTSD level? There's a questionnaire called perceived stress. If you've had a concussion, we can do a Rivermead post-concussion survey to say, what are your concussion symptoms? And as those improve, can we see these other things improve as well? So getting that data as a baseline and really knowing where to focus our treatment protocols, one, keeps people off the internet, taking every single supplement they see marketed for memory impairment, which I had one patient come in saying, I'm taking my red pill and my green pill. When I looked at the ingredients, it was emulsified fruits and vegetables. And it was costing him hundreds of dollars a month to take these emulsified fruits and vegetables. And I was like, or we could eat fruits and vegetables, and we can talk more about how we can actually stratify and treat your brain. So I think it takes, like I said, away a lot of the fear. It keeps me accountable as a provider to say, if we're going to check in on this every 3 months and we're not seeing an expected improvement or stagnation, then we need to change our course. We need to do more investigative work, or we need to find some more support. So it's a really important tool that I really wanted to get on here to the community and say, we have this capability now at Coeur d'Alene Healing Arts. We're doing these assessments. We're giving you the interpretation, giving you the exercises you need to do. And again, whether it's long COVID or thyroid, or you really are fearful of developing a long-term dementia, the sooner you get in, the better, because you can be really proactive with your health. And if it is an Alzheimer's disease, if it is a frontal lobe dementia, then there's a lot we can do there too to slow the progression and help improve quality of life. So kind of taking away the fear about why that exists and opening up your minds to recognize there's so much more investigative work than is being done in the conventional world right now for memory loss that needs to be explored to ensure that's the reason. So I've chatted now for about 40 minutes straight without a sip of coffee. So questions, comments, concerns. I want to open up the floor here for the next 5 minutes before we get kicked off, and really, whether it's a conversation between two of you or whether you have questions for me, please participate.
Can I ask a little bit about sleep?
Mm-hmm.
So if a person is going through kind of an acute state of stress, is it better, and it's causing them not to sleep? Is it better to take a little something to help them sleep? Like, for example, I'm talking like half a pill or one pill of, whatever they put into the kind of antihistamine that they put in sleep aids,
Right, diphenhydramine or
right.
Benadryl. Yeah.
Yes.
So you hit on a really good point here, Carla, and I appreciate you asking that question. Oftentimes, no patients will hear me say the phrase, if you are not sleeping, I will use anything short of a club to the head to get you to sleep, right? Even if it's medicated sleep. So that's a little bit of the top down, bottom up approach. Ideally, we want our brain to sleep in a very natural and circadian rhythm way. But I do understand what you're saying is sometimes, to put it succinctly, shit happens, right? If I can paraphrase in such a way that we can't get to sleep. We have the stress to not to. So again, in a top down, bottom up approach, yes, using a sleep aid is necessary sometimes. And I have prescribed them before sometimes. It is beneficial for you to sleep rather than not sleep. The issue that I'm seeing so often or not is that these sleep aids then are lasting 5, 10, 15, 20 years for people sometimes. And when you look at the common side effects of sleep aids, CNS or central nervous system depression is one of the top ones listed. And so to undo decades worth of sleep aids and knowing that the brain never really got that restorative, lowering inflammation and lymphatic work through that time, now we're trying to undo an onion that I'm not sure that we can do. So to answer your question, yes, it is better to sleep than to not, and not but, and is it important to get support during that stressful time to help limit the amount that you have to take and the duration that you have to take it.
Okay.
Does that help?
It does. Thank you.
Okay, of course.
So I have a question.
Yeah.
So I see Dr. Hunter, and I've been taking melatonin and magnesium every night forever. I don't remember how long. So I'm just wondering, and oddly enough, just last night, I forgot to take it and slept just fine.
Mm-hmm.
It doesn't mean anything because it was I started taking it during the whole, menopause, hormonal, wake up at 3 to pee and then can't ever go back to sleep thing.
Okay.
Which makes me a crazy person. And so I've always done the melatonin magnesium thing, but is that in the same genre of taking a sleep aid?
Category? Yeah, it's a really great question. Thank you. So I'll separate the two of them. Magnesium, no, magnesium is an essential element that works on a different biochemical pathway. So magnesium actually isn't putting you to sleep or aiding you into sleep. Magnesium, depending on the type, right? Is it glycinate, malate, citrate, oxide, is going to do different physiologic benefits for you. Now, the glycinate malate mix that I'm really familiar with here will help regulate your nervous system. It calms nerves down. And then the malate part helps with muscle spasms. So why it's often given as a sleep aid is that if you're having restless legs, if you're having muscle cramps, if you're having bladder spasms, if you're anxious before you go to bed, then oftentimes that will help work on that pathway to allow the body to then go to sleep. So it's not necessarily a sleep aid in the same way that something like Ambien would be. And the melatonin piece, so there's a lot of different philosophies on melatonin. Melatonin is a naturally occurring hormone that is given a lot of credit by being made by the pineal gland, which is in your brain. Interestingly enough, most of your melatonin is actually made in your gut. So I talked to a lot of people about sleep deficiency who react well to melatonin saying, oh, we probably need to do some work on your gut. I'm not going to blame your brain for that one. But melatonin can be really useful, and I'll use it. I call it a sleep retraining protocol when I'm taking people off of sleep aids for a long time, or if we're getting through, like was asked before, kind of a really stressful point in our life where we just need to teach that brain, hey, this is time to make melatonin. And this is what we need you to do. But I often use it, like I say, as a retraining protocol. Our brain is plastic. It can learn, it can grow, it can change and adapt. So when we reinforce those behaviors for a certain amount of time and teach it, this is sleep time, and we do all the lifestyle adjuncts, I usually don't prescribe melatonin for more than 6 months to a year. if we can get people back into that normal circadian rhythm. And again, if you're responsive to melatonin and it doesn't work when you don't take it, then my next focus would be your gut, because that's where the majority of your melatonin is actually made. Does that make sense to you? Did that answer your question?
It does, it did, thank you.
Okay, of course.
Can you repeat the two different types of magnesium that you were talking about?
Yeah, magnesium glycinate is a form that's often used for people who have anxiety or neurologic conditions. It calms the nerves down, so it can be a nervous system regulator, and it often helps, like I said, with anxiety and that sympathetic tone dominance. And it's safe to take during the day. It's not going to put you to sleep. It actually is an anxiolytic. We use that to help calm anxiety in place of like a benzodiazepine. Magnesium malate, remember malate for muscle, is going to help calm muscle spasms down and relieve, people who have restless leg syndrome, people who wake in the middle of the night with foot cramps, different things like that. Magnesium can help there. Keep in mind, again, magnesium as an essential element is often deplete in a lot of people, just like a lot of our elements are, but also interferes with a lot of medications. So it's not always safe and benign to just take it willy-nilly, right? You have to talk to your doctor about when you're taking it and what it interacts with. Now, magnesium citrate and oxide, not well absorbed in the gut, and they're going to help you poop. So a lot of times when people are taking that and they say, hey, I feel a lot calmer when I take it, I don't know what you're talking about, it works on my nervous system, I kind of giggle in my head and say, well, it works because you pooped, so you feel better. But I don't say that. I just, that oftentimes is what happens. When you have a bowel movement, you're going to feel a little less anxious. So there's a lot of different forms of magnesium. There's a lot of different forms of all these essential nutrients. And I said, quality assurance in the supplement industry is not regulated. So please be cautious when you're taking and experimenting with nutraceuticals. Another one I get commonly asked is 5-HTP or tryptophan. These are amino acid aids that are often used for mood stabilization and sometimes sleep. These interact with SSRIs, and they interact very strongly with antidepressants and sometimes your thyroid medication. So just another example of, things are not always safe and benign, and talk to your doctor for sure if you're taking anything. So much of my practice is undoing at the beginning and then rebuilding and say what's working, what's not, what's safe, what's tolerable, what's interacting. So we don't have any more questions. You can always email the clinic, info@cdahealingarts.com. I'm really open. You can CC Dr. Karin. Hey, a question on the open forum. The ladies will send it to me. I ask for a little bit of grace period in responding because I'm still, running my practice here, but usually we'll get back to people within a week. If you have a question or concern, I am seeing people and open to new patients right now. And if you're seeing another provider in the practice and you're interested in doing a cognitive assessment, they can refer you to me for a 30 to 60-minute consult to do an evaluation, to get a baseline score. And then I kick you back over to your provider. And then every 3 months we can repeat and make recommendations to you or your provider on how to kind of proceed with that aspect of your care. But suffice it to say, to kind of end the lecture today, just to reinforce, so much more people are fearful of losing their mind and their mental capacity, and they're so late to the game and being proactive about it. And the same goes for your care providers. Are we recognizing the prodromal or the symptoms that come before memory loss, just like we would recognize the risk factors for a heart attack? And the answer is no. Are you getting screened for trauma? Are you getting screened for mental health concerns, your ACEs score, your current nervous system state, thyroid, autoimmune? Are you getting screened for these things ahead of time to know that this won't develop into cognitive changes? And if not, and you're concerned about these things, then find a provider who will. And don't discount your kidneys. It turns out when I became neurology focused, that kind of paired with urology focus. So they work together. Okay, you guys, I so appreciate you showing up. I was really hoping people would be here and participate. And again, send questions, ask questions. If you found this helpful, it will be posted to our website and our social media page within the week. We do these to serve our community, to offer free education, empowerment, and resources for the community. So if you did find it helpful and useful, please share it with your friends, family, whoever you think it might be valuable for. And then shoot me a message if you have questions. All right, take care.
Thank you.
Bye now.